Thing we're going to do in assessing the upper quadrant, and more specifically the SC and later on the AC joints, is to get a bird's eye view. All right, so sit your patient up nice and straight and look down at the position of the shoulders. If you can just artificially roll these forward for me, just look at where they are relative to the head, and kind of this bird's eye view gives you a nice picture from above of how much those shoulders are rolled forward. So now I'll relax it, bring it back. So again, have your patient seated and look from above. After that, we'll actually assess the flexibility by taking our hands and holding on to the front of the shoulders with our thumbs in back, and then see how much give there is when we try and bring this back. In a patient with a chronic forward shoulder posture and compression at the SC joint, you might notice that this is very, very stiff. All right? So see how much give there is. I'm bringing this back. I'm also pushing down on it. My thumbs are actually on the spine of the scapula. Another way to accomplish this on a patient who's much bigger than you is to turn your side to the patient's mid-upper thoracic area, and then take your forearms and use your forearms to pull the shoulders back and down. Again, seeing how much give there is there. And for someone who has SC compression, by the way, that's probably going to feel pretty good. The next thing we're going to do is palpate for the general range of motion of the SC and the AC joints. So to do that, we're going to take a very broad contact. We're going to just get some digits near the SC joint, some digits over the middle of the clavicle, and now I have some digits near the AC joint as well. What I want to attain here is to have my patient go through range of motion in elevation, depression, protraction, and retraction. In other words, rolling their shoulders. So first I'm going to have you shrug up and roll back, shrug your shoulders up, all the way up, and then roll back and down, and then come around again. So once you train your patient to do that, have them go through a few cycles of that. And then have them reverse direction. Have them come up and go in the opposite direction. So you're coming up and forward now. Up, and now roll forward and back down. Up, and roll forward and back down. Now I'm noticing a little crepitus on the right, not painful, correct? Just some noise. You will notice that these joints sometimes are noisy. Sometimes it's the noises made by the scapula rubbing over the back of the chest wall. Noises are just normal sounds that these joints make, and unless they're accompanied by specific symptoms or complaints, they're usually just coincidental in nature. So we're looking, with this test, it's a very general test, we're looking for just gross asymmetries. Any excessive clunks or movement that might take place, any gross asymmetries between how both sides are moving, one compared to the other. The last thing we will do as part of this assessment is to palpate the upper traps. Patients with compression in the SC joint often have hypertonic upper traps. And the hypertonicity, if it's found more outbound, in other words, out more towards the shoulder, it's said to be more related to the SC compression. If it's found in very close to the CT area, there seems to be a correlation more with CT, cervicothoracic types of problems. So just palpate along the upper trap, seeing where that hypertonicity seems to be localized. Is it more outbound towards the shoulder, indicating SC compression, or is it more inbound towards the cervicothoracic junction, indicating perhaps some cervicothoracic issues?